Welcome. Thank you for taking the time out of your schedule today to join us for the first of our Rural Innovation series. We're grateful that you took the time to be with us and want to introduce our presentation today. Before we get started, just a brief housekeeping. We are going to be accepting questions throughout the conversation in the chat and the Q&A, but please note we will be holding that until the end. So if you want to go ahead and throw your questions in so you don't forget them, please feel free to do so. Just keep in mind that we are going to be pausing on that. And today I would like to introduce our presenter, Whitney Pruitt. She is a dedicated nurse practitioner with over 12 years of experience in healthcare. She began her career as a registered nurse, earning her associate degree in nursing from Hari Georgetown Technical College. She then pursued her Bachelor of Science in Nursing from the University of North Carolina, Wilmington, followed by her Master's of Science in Nursing from Post University. Whitney completed her Doctor of Nursing practice at Francis Marion University. She currently serves her community by working at a federally qualified health center in the southeastern area of the United States. There, she is committed to improving access to healthcare for underserved populations. She balances her professional career with family life, being married with 2 children and 2 dogs. Her passion for rural health and patient advocacy drives her commitment to providing high-quality care and contributing to the development of nursing practice in global rural health settings. Now, I would love to turn it over to Whitney. Good morning.
Good morning. I'm going to attempt to share my screen here.
There you go.
Okay, so good morning. Hello, everyone. I'm Whitney Pruitt, and thank you for the introduction. And thank you for allowing my research to be included in this Rural Nursing Innovation web series. Today, we will be discussing a quality improvement project that I completed in a rural area of the southeastern part of the United States, titled Improving Colorectal Cancer Screening Referrals in a Rural Health Clinic. So the objectives of the project are to explain the significance of increasing colorectal cancer or CRC screening referrals, review guidelines and recommended goals for colorectal cancer screening, identify patients eligible for colorectal cancer screening using the CRC risk assessment tool, and to discuss an intervention to improve colorectal cancer screening referrals in a rural health clinic. So colorectal cancer is asymptomatic in its early stages. Despite being preventable with early detection, is actually the second leading cause of cancer deaths and is responsible for 8% of all new cancer diagnoses. With projections of 153,000 new cases and over 53,000 deaths in 2024. The American Cancer Society and the United States Preventative Services Task Force define average risk as patients who do not have a history of colorectal cancer or a family history of colorectal cancer in a first-degree relative, colorectal polyps or adenomatous polyps, inflammatory bowel disease, someone who has had radiation of the abdomen or pelvis due to cancer, has suspected or known inherited cancer syndromes such as Lynch syndrome, or has familial adenomatous polyposis. So screening recommendations. There are multiple methods that are recommended for screening colorectal cancer. Non-invasive screening methods include the fecal occult blood test or the fecal immunochemical test. They call it the FIT test. Which are both stool-based tests that check for the presence of blood, which might suggest a polyp or cancer, and they are done annually. Another non-invasive stool-based test is the Cologuard, which checks for certain DNA mutations and blood in the stool. It's typically recommended every 3 years. You also have the flexible sigmoidoscopy, which examines the lower part of the colon and is recommended every 5 years. And lastly, you have the colonoscopy, which is an examination of the entire colon and the rectum and is done every 10 years. According to the American Cancer Society, the national goal is to screen 80% of all eligible patients for colorectal cancer. Yet, at the project site, there had only been 10.4% of patients who had been screened. So the evidence review, it revealed that colorectal cancer screening is crucial for early detection and treatment, significantly reducing mortality rates. However, screening rates are worryingly low, especially in rural and underserved areas. The findings identified barriers to colorectal cancer screening in those areas, and they include lack of awareness, fear, financial constraints, and insurance coverage. There's also limited understanding of the screening test and widespread ignorance about colorectal cancer and its risk in rural communities. Several studies underscored the effectiveness of education and awareness programs, and the evidence strongly suggested that provider-led patient education can enhance colorectal cancer screening rates, especially in those particularly rural areas. The setting for the project was a primary care clinic, which was also a federally qualified health center located in a rural area in the southeastern part of the United States. There were 2 full-time nurse practitioners who participated in the project. So methods. The population of focus were patients who were at average risk for colon cancer, and the inclusion criteria for the project were patients who were aged 45 to 75 who were at average risk for colorectal cancer based on the current guidelines, and they were also patients of the clinic during the month of May 2024. Exclusion criteria for the project included patients at high risk for colorectal cancer, patients who are less than 45 or older than 75, patients who were not patients of the clinic during the month of May 2024, and patients who had recent colorectal cancer screening, and so they were up to date on their screening. And lastly, patients with severe comorbid health conditions who have a limited life expectancy. So staff education was completed via PowerPoint presentation. It included the importance of screening, colorectal cancer risk, and guidelines for the screening. The CRC risk assessment tool provided the streamlined process to properly identify patients who needed to be referred. The intervention took place during the month of May 2024, and the goal was to increase the referrals of average risk patients for colorectal cancer screening. To the right, you'll see the CRC risk assessment tool that I used. The top portion was filled out by the medical assistants, and then the bottom portion was for the providers. The CRC risk assessment tool was created using current national guidelines, and its validity was confirmed by 2 project site providers and the nursing faculty member at Francis Marion University. It was given to patients on printed paper and without asking for any patient identifiers. Then chart reviews were done by the primary researcher using the electronic medical record. The primary outcome of the intervention was the percentage of colorectal cancer screening referrals. The pre-intervention referral percentage was calculated by dividing the number of patients referred for colorectal cancer screening in May of 2023 by the number of eligible patients for colorectal cancer screening in May of 2023, then multiplied by 100. And then the post-intervention referral percentage was calculated in the same way, but it was for May of 2024. The demographic data included age, race, gender, and geographic location, and it was de-identified and aggregated for analysis. Pre and post intervention colorectal cancer screening referral percentages were compared before, which is May of 2023, and after, which is May of 2024, implementing the CRC risk assessment tool. An increase in colorectal cancer screening referrals post intervention would demonstrate that the project was a success. The project was implemented during the month of May of 2024, with the medical assistants completing the CRC risk assessment tool and the providers referring the patients based on that tool. So they were referring them for screening. So the primary outcome of the intervention was the percentage of colorectal cancer screening referrals. That's what we're looking at for the outcome. The result was an increase of colorectal cancer screening referrals going from 13.4% during the month of May of 2023 to 34.9% during the month of May 2024. Of the patients who refused referral, the majority, which is 69%, cited a fear of having the procedure, such as a colonoscopy. Additionally, 21% of the patients did not provide any reason for the refusal, and 10% expressed having a fear of receiving results. When gender and race were compared, the results showed that men and minorities, including African American and Hispanic, were the majority to refuse the referrals, with 85.7% of men refusing compared to 50.8% of females and 81.5% of minorities refusing compared to 59.2% of Caucasians. The primary outcome of the quality improvement project was a significant increase, as you just saw, in colorectal cancer screening referrals from 13.4% to the 34.9%. The improvement suggests that the educational intervention and the implementation of the CRC risk assessment tool were successful in increasing the referrals in colorectal cancer screening. Fear of the procedure, test results, and stigma surrounding colonoscopy still persist. This shows that there is a need to address these misconceptions and fears about colorectal cancer screenings. Additionally, demographic disparities were noted, with a disproportionate number of referrals among Caucasian females and lower referral percentages among African American patients and men, despite there being a higher mortality rate from colorectal cancer in these groups. These findings underscore the importance of targeted interventions and address specific barriers faced by different demographic groups. The strengths of the project were that the project saw significant increase in colorectal cancer screening referrals. The success was largely due to a combination of thorough staff education and the introduction of the CRC risk assessment tool. It was very user-friendly. This tool simplified the referral process and made it easier for staff to identify and refer patients who were at risk. By implementing the initiative in the rural clinic, it addressed unique challenges that rural clinics often face, such as limited resources and access to care. The limitations of the project were the high refusal percentages that were largely due to the patient's fear of colonoscopies, which we spoke about, and their unwillingness to try alternative screening methods. The data also showed a disparity in acceptance rates. More Caucasian females accepted the referral, whereas minorities did not. It's important to mention that the project was conducted over a 1-month period, which may not fully capture the long-term sustainability of the intervention. Additionally, the project did not track whether patients actually completed the recommended colorectal cancer screening, which is a critical step to measure the true impact of health outcomes. Future projects should incorporate more intensive patient education, like handouts that highlight the importance of screening and detailing different screening methods. Culturally sensitive education should include outreach within the community setting, utilizing local government and social media. Clinics should also incorporate a CRC risk assessment tool into the EMR to improve screenings. The initiative should be expanded to other preventative screenings to improve health outcomes of patients in rural areas. Long-term follow-up studies should be used to assess the sustainability of the increased referrals, impact of recurrent education for patients who refuse a referral, and the impact of the actual screening completion are also suggested. So in conclusion, the project successfully increased the number of referrals for colorectal cancer screening in the rural health clinic, demonstrating an effectiveness of targeted interventions. However, it's important to note that certain barriers to screening still remain, particularly among male patients and minority groups. The success of the initiative suggests that broader implementation in other rural clinics could have a substantial impact. By expanding the initiative, we have the potential to significantly reduce mortality rates and improve overall public health outcomes in rural communities. Thank you all, and that concludes my presentation today.
Thank you so much, Whitney. At this time, I want to open this up for any questions. You can use your chat feature, your Q&A feature. If you'd prefer to ask your question yourself, you can raise your hand and we can unmute you. So while we're collecting those questions, if there are any, I just want to remind everyone that this is our first of an 8 series of webinars for the Rural Innovation Series. Our next one will be in October, so please do check our website for that schedule. And if there are any questions that might come up after the fact, you can always reach out to us directly. We can put you in touch with Whitney and share that information forward. So are there any questions? Okay. Well, and interested in keeping everyone's schedule, we will go ahead and sign off for today. Again, thank you for signing in, taking your time. Whitney, we are so grateful for you to share your research with us. And we hope everyone has a wonderful day.
Thank you so much for having me.
Thank
Bye-bye.
you.